questions or comments? Yes, Sasanka.
Roxanne, it's excellent lecture. Thank you so much. And thank you for presenting this great case that we did together. So this case was a really important case for entire Sikh Heart Center. We actually learned great deal from this patient. This is one of the first stunts we did, but still one of the most extremes. He was 32 weekers, 1.5 kilo. So that's why we initially did a main PA ligation to really avoid the cardiopulmonary bypass. There's a couple of things. One, this open duct with bilateral pulmonary artery banding actually works in this very small premature baby. That was really nice to know. And so this patient actually survived actually cardiopulmonary bypass doing the delayed stance on the middle of the night. That was also a great learning. In terms of the fetus who have a high drops and really struggling and have a significant risk of fetal demise, this type of sort of a modified procedure may work better. And the last comment is that he's probably 7 or 8 years old. I saw him in the clinic. He's doing great.
Um, I love his case as well because it speaks to, well, you can't always win the day, so to speak. You commit to a plan, you hope it works out. You can't always sort of win the day and have that satisfaction of like it really panned out. The learning was there for multiple other patients, but because it worked for him, it leaves you with this ability to sort of reflect back and understand why it's not always just black and white as to whether you shouldn't offer or should offer when you're working at a place that can actually push the envelope in certain directions. So I think it's a nice case from multiple lenses, including the ethics lens.
Oh, fantastic talk. And it was really amazing how you were able to take what also was presented and make something more interesting and fantastic. I was curious. I was waiting to see if anyone would ask about the lung hyperplasia. So when I was a medical student, I knew nothing about really anything. Didn't even realize that fetal cardiology was like new. But when we published that paper in JACC in '91, there was this finding on fetal fetuses that had termination of pregnancy and on that had like half of them had small lungs. Lung weights were small. These were very bad cases picked up at 20 weeks with horrible ultrasound technology at the time, right? Because it's like in the 80s and everything was just grainy and I can't even believe all that they saw with these huge hearts at 20 weeks. But in fact, actually, a lot of I think that lung hypoplasia is actually relatively rare in the cases that we see at birth, to be honest. And this is in part because, and Lindsay can attest to this, many of those, they're the ones with massive cardiomegaly at 20 weeks. You even see them at 14 weeks. You make these diagnoses in the first trimester. But a lot of them develop the massive hearts really with time and really in the third trimester. So there's already been time for the lungs to grow. And so you see, that's why I was saying wall-to-wall hearts. They're all wall-to-wall hearts. They don't tell you anything. Exactly. That's like not useful to me at all. Like I never look at their x-rays because they're useless. But the interesting thing is of all of the ones that we've seen and had survival, and sure, maybe some of the ones didn't survive. And when we wrote that paper too, it was the babies that were hard to ventilate. Well, sometimes they can be hard to ventilate because they have massive hearts. And we had no idea what the pathophysiology was back then. So I don't know that they were challenging to ventilate. It wasn't just our lack of knowledge about this disease, right? And I've only had one where the PVR, like that case I think you were talking about, where the lungs weren't perfect, but the PVR actually didn't come down.
Yeah.
Only one out of all of the ones that we've been managing who did survive, which in our situation is the majority for sure, including some of the worst ones. Only one that we couldn't get the PVR down, we couldn't get the PA pressure down no matter what we did. And at the time, it was before we were doing kind of stars for the most severe end of the spectrum. I'm not sure that lung hypoplasia is a humongous element here at all. And some of it is that you're seeing them only after the 40 weeks. And if in the last 10, 12 weeks, they've really had massive cardiomegaly, the development of a circular shunt, et cetera, probably the lungs have been okay. Go for that kid, go for that kid and figure out the pathophysiology that you got in front of you.
Yeah, I completely agree. I mean, there's a few important points to pull out, which is, yes, the lung development is different because the space occupying lesion happens later in gestation, so you have more opportunity. And I would completely agree. You don't want to overemphasize the lung hypoplasia as the key rate limiting factor. And what we've learned in doing this, and more than just this patient, but some of these, especially when they're prem, because they're of course interrupted in their lung development anyways, is you get rid of the space occupying lesion and you get a bit of time. There is an interesting pathway that there is some further lung development that can happen. And so the patience of, yes, I know the lung compliance isn't great right now, but we can actually get to a place where this patient doesn't long-term need ventilation is possible. But it's I think an evolving piece of the knowledge that we have to put together so that we can tease out earlier which ones are like, don't, that's not going to be a rate limiting factor. This might be an important part that you're going to have to wait through, and then how to best ventilate them. And there's so much work in the NICU and in the prems on maximizing how you optimize lungs that are small or early, that we just need to integrate some of that learning so we can do it a little bit more predictively and a little bit less live time, moment to moment judgment decision making, and a little bit more informed as possible as we kind of continue to evolve the field.
Thank you, everyone. In the interest of time, we'll conclude our session here. I'll thank our speakers once again, Dr. Kirsch, Dr. Freud, for sharing your expertise through those excellent talks, and to everyone for a very nice discussion. We have about 10 minutes for a coffee break, and we'll reconvene at 11. Thanks, everybody. Yeah, it might be.
Okay, so welcome back, everybody. For the next session, it's a great pleasure to invite my colleague, the head of cardiovascular surgery at SickKids, Dr. Osami Honjo. He and I have been on staff together at SickKids, and in fact, before that, we were fellows together. Around 2006, I think, and then came on staff in 2010. And Asami became the division head at the beginning of this year. His expertise includes open heart surgery for neonates and infants with congenital heart disease, surgical palliation for single ventricle patients, and mechanical cardiopulmonary support in the pediatric population. And he also specializes in adult congenital heart disease surgery. And since 2012, he has served as the surgical director of heart transplant and mechanical circulatory support at SickKids. So welcome.
Thanks, Mike. And good morning, everyone. Hopefully you're enjoying the symposium so far. There's a lot of great talks already. So unfortunately, our guest speaker, Dr. Van Stans, is not able to come. So instead, I'll give this lecture. So this is about the exclusion of the right ventricle, particularly about patient selection and long-term outcomes. First, we want to acknowledge that this House lecture is generously supported by Dr. Robert and House Endowment Fund. So Dr. House graduated from the University of Toronto, Faculty of Medicine in 1949. And after training in pediatrics and pediatric cardiology at the University of Minnesota, he returned to Toronto as a staff cardiologist. So he joined SICKIS in 1955 and played an integral role in the Department of Cardiology for many decades, while maintaining a busy private practice and then also teaching at the University of Toronto. He was known not only for his excellent clinical skill, but also for the deep kindness, compassion, and empathy he extended to every patient and family he encountered. Dr. Diedenhaus was also deeply committed to his community, leading the pediatric department at Bronson Hospital, volunteering with the Canadian Jewish Congress, and chairing its chaplaincy service committee, where he brought comfort to countless individuals. Through this Diedenhaus lecture, we honor his memory and his outstanding career by continuing to foster excellent compassion and innovation in child health. Today, we're absolutely thrilled to have Nathan and Sheldon Diedenhaus in this room, and we'll give a lecture on behalf. So I just want to also acknowledge Dr. Baron Stearns. Unfortunately, he is not able to make it, but my talk is really about his innovation. So he's a distinguished professor and chairman in Department of Surgery at University of Southern California. So he's really most influential congenital surgeons and transplant surgeons in his generation. Obviously, he invented Stearns procedure. His first surgery was 1988, but reported in 1991. I also learned that he performed the first living weighted double lobar lung transplantation in 1993, and then has been leading many of the groundbreaking research as well. Recently, he was a president for American Association for Thoracic Surgery. So my talk is really, I'll mainly talk about his innovative surgery and then its outcome. So, so the main topic is exclusion of right ventricle, its procedure, patient selection, and long-term outcome. So I just want to touch on the basic concept of this procedure and the original description of Dr. Stearns, and surgical strategy and practice patterns of neonatal Ebstein anomaly over the 3 decades, recent trend. I'll touch on just a little bit about consensus statement, although Dr. Konstantinov have a separate talk tomorrow morning. And then long-term outcome, single ventricle palliation following this Stearns procedure. So I'm not going to touch on the biventricular conversion strategy because we have a guest speaker to talk about it in later on. So this is original publication that Dr. Stern published in 1991. So at that point, the infant with symptomatic Ebstein anomaly mortality was ranging at least 50 to 75%. It's very high mortality with no reliable surgical strategy present. And the previous attempt of sort of many type of palliative surgical strategy had the equal dismal result. So he and his team performed the first Stearns operation in May 1988, and in this first publication, he reported this 5 first patient in detail. Just as a background, in this publication, he did mention in quite detail there's 2 major publications leading to this innovation of procedure. So one is, this is probably one of the first sort of multi-center study to look at the natural history of Ebstein's anomaly. It was published in 1974 as you look at this, the patient who have a Ebstein diagnosis and then diagnosed less than 1 year of age, their outcome is quite dismal, greater than 70% mortality among those population, not surprisingly. And in this era, at least 60% or more surgical mortality among the 17 patients who are 1 to 15 years of age. So this is quite dismal outcome. And then you can see this, many of them have sort of the palliative procedure to augment pulmonary blood flow, but that didn't go very well. The second important reference he mentioned in his first publication is this study from the San Francisco. And so this is more of a natural history type paper talking about 16 consecutive Ebstein anomalies of 5 fetus and then 11 neonates, and then mainly talk about sort of echo-based characteristics to see the prognosis. So in essence, so this the 16 patient, the 40% of the patient died by 3 months of age. And they described that there's an echo sort of characteristic of non-survivors that include RV dysplasia, abnormality of anterior leaflet, and large right atrium, and so on. So those are the characteristics that Dr. Stern and team used to sort of make an indication for his surgical procedures. As I said, so this is a clinical characteristic of the patient who did not survive in this study, and many of them are repeated in multiple presentation from the morning, and then nothing surprising. But their conclusion is that those the echo features of severe Ebstein's related to the mortality, RE mortality. So just coming back to his original description, so this is this consists of 5 patients and all neonate, and then all patient cyanotic with the PO2 of in the low 30s. And majority of them have a systemic acidosis indicating compromised systemic output. So all are intubated and have a massive cardiothoracic ratio. So all patients have a functional pulmonary atresia, but none of them have a circular shunt, as far as I can tell. So this is, I found this really fascinating. So 2 of the 5 patients, in fact, underwent cardiac catheterization prior to intervention, and their mean arterial pressure was 9 and 12, respectively. And you can see the step up. So this is right ventricular pressure, systolic pressure is in the low 40s, but you see that pulmonary artery pressure is much higher than the right ventricle. So this is like a true demonstration of functional pulmonary atresia in those patients. So this is a description of Stern's operation. They did sort of a standard cannulation, but they did cool down to almost sort of a deep hypothermic circuit arrest level, so cool down to 20 degrees with the low flow perfusion. And they perform atrial septectomy and closure of tracheal valve orifice. I didn't know about until I read this, but Dr. Stearns placed the coronary sinus on the right ventricle side, which we tend to leave it in the right atrial side. The first 3 patients he described, they did not place the fenestration on the Stearns patch. I'll get to that in a subsequent slide, because that have an impact on their clinical outcome. The right atrial wall is reduced and enclosed, and then the Dr. Stearns placed this 4mm center shunt, which it seems pretty big, but so that's what they did. They left the pulmonary valve open. And so this is interesting sort of a combination of medication they administer to manage those patients, mainly because they did not create the fenestration at the stance patch. So they kind of described a way to decompress the right ventricle through the patent pulmonary valve. So it's a dopamine, epinephrine, and then they kept the prostaglandin and then hyperventilate the patient. In order to allow pulmonary valve to open every now and then to decompress the right ventricle. So this is how they describe. So obviously, there's a marked reduction in the cardiac size after stunt procedure. And among those 5 patients, there's no early deaths or late deaths, which is really remarkable outcome, given that those patients have at least greater than 70% risk of dying before this. And the one patient underwent a Glenn operation at 11 months of age, and 2 patients, in fact, have sort of a primary Fontan operation after Stearns around 2 years of age, and then the 2 patient remains stable. So that's the description. And then, so this is, how Dr. Sun described in his discussion. So his design of this procedure is aimed to provide a reliable pulmonary blood flow and to reduce the mass of cardiomegaly and then abolish the tracheal valve regurgitation by closing off the orifice. And this is to create a bridge towards either the further definitive procedure, which is Fontan or transplantation. So he described that previous palliative procedure focused on pulmonary blood flow, such as BTT shunt, Glenn shunt, PDA manipulation, but he emphasized on dealing with severe tracheal valve regurgitation and then cardiac mass. And he said this therefore essentially create surgical tricuspid atresia. Subsequently, so that was the 1991, and then this is probably one of the most significant publication in RE 2000. So this is a multi-center study from Europe, including 150 patients. Obviously, this is from neonate all the way up to middle-aged adults. It's about 10% of the patients are neonate or infant. And you can see this exceedingly high mortality. So this palliative procedure that's mostly happened in neonate and infant, 75% mortality. And the patients who are either neonates or infant, they have about 50% mortality. And then interestingly, so this is a palliative procedure. So not many patients actually have this category in RE 2000, but the only 3 patients have sort of a Stearns or a modified Stern type procedure involving the tracheal valve orifice closure. And then many other patients are dealt with BTT shunt or center shunt type procedure. So the Stearns procedure was obviously not widely performed in this 1990s or 2000, and then conventional palliation strategy in this era was associated with exceedingly high mortality. So in that era, same era, the neonatal biventricular repairs report. This is Dr. Nock Craig's. He pioneers this neonatal biventricular repair with sort of a unicasp type repair. And then one of his reports shows the survival of 54% if you have a pulmonary atresia, anatomic pulmonary atresia, and then 90% survival if you don't have a pulmonary atresia. So this is one of the report from Japan. Interesting report in the sense that they attempted a couple of neonatal cone reconstruction But you can see that this outcome is really dismal. So even the Stearns, they attempted 5 patients, survival only 20%, and then neonatal COM 60% early survival. And then to just move forward to more recent era, this is also quite important publications in more recent era. So this is the Society of Thoracic Surgeons database, including quite a lot of patients. So more than 500 patients from 95 centers. That's included 250 neonates. So this is probably the largest series, radical surgical series to be reported to date. The only thing about this Society of Thoracic Surgeon database is that they only report the RE outcome. So, so among this neonatal patients, about 250 patients, approximately 40% underwent a biventricular, some form of biventricular repair, and then 20% have a BTT shunt only without excluding the right ventricle. And very surprisingly, this is 2010 to 2016, but only less than 10% actually underwent Stans procedure. And then, not surprisingly, their mortality is quite high. Biventricular repair mortality is 33%. Stans mortality, which was done quite infrequently, was 25%. So the observation from this paper is that the Stans procedure is not widely used in even in early to mid 2010s. And in this report, Stans procedure is associated with relatively high RE mortality. And then this important paper from our Dr. Freud, I cannot find the recent picture, so maybe it's time to take a new picture. But I think this is it's really a practice changing multi-center study, and we have learned quite a lot from this series of publications. So Lindsay shows part of it, but I just want to focus on this surgical outcome part. So the 2005 to 2011 and 23 centers involved in this multi-center studies, and 154 patients received active treatment. So so this patient group on the red box, 71% have either interventional catheterization procedure or surgical procedure. So Lindsay already showed this, but I think this is really important. The outcome showing that there's a by far the best surgical outcome achieved at the Stans right ventricular exclusion procedure among the highly specialized centers. So this is probably very different from the other study I just showed you. The STS database includes close to 100 institutions. And then this is more of a highly selected subspecialty institutions. And then also highlight that there's a pretty high risk biventricular repair and then very high mortality, and then shunt only strategy is also associated with high mortality. So the Dr. Konstantinov, he will discuss in very detail tomorrow morning about this consensus sentiment that he led and then published last year. But there's a 3 recommendation around this high-risk neonates who are unstable, and the recommendation around the Stans procedures. So again, this is talking about unstable neonate, particularly the one with the circular shunt. So the patient who presented with a circular shunt, we had to have an emergent interruption of circular shunt in in either Stearns RB exclusion or at least main myopathy ligation. So neonate with Ebstein's anomaly who present with refractory cardiogenic shock should be piloted with a Stearns procedure. And then the third recommendation is that neonate with Ebstein with a circular shunt with low right ventricular systolic pressure measured by the echo TR jet should undergo main PA ligation and or stance procedure. So this is, I just want to show you the couple of sort of snapshot of sick case outcome. So this is just chose extreme neonates, not all the Epstein. So this is, you can consider this as severe Epstein with systemic cardiac output compromise. So there's 15 of them over 10 years. So the about 1/3 of them went straight to Stearns, and then some have a high-risk neonatal biventricular repair, but both of those patients end up having the Stearns in a delayed manner. And then some patients have a oral delivery, and then eventually have a Stearns. Some patients end up having really good outcome by PDA ligation, and so on. So at the end, a total of 12 patients underwent a Stearns. And so this is one of, hopefully it's gonna run. So this is a patient that originally have a neonatal biventricular repair by Dr. Barron. And then the right ventricle fails. And then we just did a sort of delay Stearns. But in the beginning, we looked the tragus valve morphology very, very carefully, because this is a recent patient, and we know that we could do biventricular conversion potentially. And so this is a Gore-Tex patch sew into the tragus valve annulus. So I tend to sew this to the tendon of Trado above the conduction and then along the coronary sinus to avoid the conduction block. This one I didn't clip it, so it's gonna be a long video, so I'm just gonna have to skip it. But so this is it, and so you can also see the we already did a atrial septectomy to have a large atrial septal defect. This is where we're sewing along the sort of mass of coronary sinus, leaving the coronary sinus in the right atrium, but also avoiding the conduction block. So this is the sickest experience of 12 patients who underwent a Stearns operation. So the one patient had a BTT shunt initially and then had a Stearns operation. Two patients underwent high-risk biventricular repair as a neonate and then didn't tolerate and then have a Stearns. So one of the patients was the first patient that's presented in RE morning. So one patient passed away due to chance thrombosis, but more than one month after surgery. But otherwise, about 90% the patient survived to discharge, and most patient, so 7 patients underwent Fontan so far. And those original 2 patients who initially underwent biventricular repair, after the Stearns, they converted back to ventricular physiology at the end. So this is algorithm. The Roxanne already showed it, but I just want to emphasize that we're just talking about this right sort of the left bottom panel. So we are really looking at this right ventricular systolic pressure by echo, and then if it's low, with combination of circular shunt, we really don't hesitate to do a Stearns as a bridge to decision, as a bridge to either single ventricle or two ventricle conversion. So I just want to talk about long-term survival, long-term outcome of those patients. So we do have a lot of concerns of those patients, even though they survived Stern's operation in the neonatal period. So what are the concerns? So one is is the hypoplastic or underdeveloped branch polymyalgias. They're quite small. Sometimes it's strikingly small as a neonate, and then sometimes it's failed to grow with a BTT shunt or Stern's physiology. Patients have various degree of hypoplastic lungs. Whether or not that's going to expand over time is sometimes questionable. Sometimes they have a high pulmonary pressure or high pulmonary vascular resistance. And then some of patients may have lymphatic abnormalities carrying over from fetal period. So what are the outcomes? So this is Dr. Stern's center's outcome. This is the largest single center study, but you can see how rare this condition is. He have by far the largest single center series, but only 27 patients in this more than 2 decades. And among this 27 patients, about one-fifth of them have a circular shunt. And this is sort of a flow chart. So the first 3 patients, when they started the Stern's operation, they got non-fenestrated Stern's patch, and then two of them died. And then after 3 cases, they switched to sort of fenestrated patch, and then that's the outcomes. So, and then 21 out of 27 patients reached the Glenn procedure, and then after that, they have a pretty good outcome to follow. So this is what they describe. So obviously, by doing the Stern's operation, they decompress the right ventricle. So cardiothoracic ratio is getting small, and then stably small. And then the right ventricle was huge initially, which is kind of nicely decompressed. And then you can see this normal septal curvature at the bottom short axis. So this is nicely describes the cardiothoracic ratio, greater hormone to straight ratio, and then septal impingement ratio is all becomes very favorable by the time of pre-discharge or pre-stage 2 palliation. And so this is the overall outcome of 27 patients. So 10-year survival was 76%, which is remarkably good compared to other type of procedures. So this is excluding first 3 patients who didn't get the fenestration on the Stern's part, and that's even greater survival. And then what's remarkable is that after the initial recovery period after following the Sterns, it's not much late death through the rest of the stage 2 and stage 3. And so this is the medium-term functional outcome among the patients who have a fountain circulation. This is quite remarkably good. So most of the patients, in fact, have a normal LV function. Majority of them have NYHA class 1, and then majority of them are sinus rhythm. So this is quite remarkable outcome. And then, so I was scrambling to get this presentation prepared last night, and then our chief fellow Victoria gave me this really interesting article. This was just accepted the end of the May this year, so this is really fresh. The publication to look at the Fontan outcome among the Ebstein's anomaly. So this is the largest registry, Australian and New Zealand registry, to look at Ebstein outcome compared to other type of Fontan patient. So among 1,600 patients, obviously only 30 of them have a Fontan anomaly. And among those, only 18 patients have a previous Stern's operation. So we're talking about very narrow subgroup, but it's still quite important. So compared to, so red is the whole cohort, and then blue is all patients who have a Ebstein, regardless of Stearns or non-Stearns. So if you compare to all the single left ventricle morphology Fontan, which is in the red, Ebstein patient do worse in terms of survival and freedom from Fontan failure. And if you look at this 18 patient who have initial Stearns and then subsequent Fontan operation, so this is so good trees, median follow-up of 4 years. So they have no late mortality, no Fontan failure, and they have comparable survival compared to tricuspid atresia. So this is, I would say, I was quite surprised in positively. I thought they may have more problem after the Fontan completion, but in the medium term, this only 4 patients have more than 10-year follow-up in this series, but medium term outcome is quite encouraging. So so they said as a whole, so Ebstein anomaly, so 34 patients among 1,600. They do worse compared to the patient who have morphologic left ventricle as a systemic chamber. But the patient who have a previous Stearns and an upper Fontan, they actually have a quite good outcome, and then they have an equivalent outcome compared to tricuspid atresia, for example. And they want to look to see if that Stearns actually makes a positive effect among the patients who have a Ebstein's anomaly, which means that if you exclude the right ventricle, decompress the right ventricle in the initial phase, that might do some good for the left ventricle in the long term. So that's what they're implying. To summarize, since Dr. Stearns performed this first successful Stearns right ventricular exclusion, I have to say it has been very slow adaptation of this procedure to neonatal Ebsteins around the world. The Stearns procedure definitely effectively decompressed the direct right ventricle and result in significant space for the left ventricle and the lungs to expand and turning physiology similar to tricuspid atresia. Stearns procedure is now recognized even in the consensus statement as a recommended procedure for unstable neonate with circular shunt or unstable neonate with systemic output compromise, particularly patients who have a low right ventricular systolic pressure. So reasonable ARIA outcome of Stearns has been observed and achieved in many centers. And limited available data of long-term outcome after Fontan operation following Stearns shows quite an encouraging outcome. But we need to see more long terms. Thank you for attention.
Thank you for that wonderful lecture, and for the Deason House family for coming and joining us. Questions from the audience? Maybe I can get us started. That last paper you showed was really interesting. And I'm trying to figure out whether the better outcomes with the Stearns is because those patients are younger. Do you think, I mean, presumably they tried to account for that, but do you think that's...
Well, it's a very small population, and they actually include that Ebstein anomaly with CCTJ. There's like 6 or 7 patients, so that might be skewing the data. But if you want to hypothesize, just like Lisa showed, you know, this something like dysynchrony or septal dyskinesis, that might be better with the stents, and you know, it's kind of excluded this bulky right ventricle from the physiology, because some of the you know Epstein's with you know but right ventricle just bulky, and then if you do the just fontan, that will stay really big and you know keeps compromising the septal function. So that I was just kind of just guessing, just reading about it, but I think you know I mean that paper is very interesting. Not enough data to kind of confirm.
Thank you. Yeah, I mean, I think the other, Lisa, did you have a comment? Pedro.
Two patients that started before this procedure, he didn't leave the administration.
Right.
And then he changed. The reason for change, leave the like spread, and I think was high mortality.
Mm.
And then improved with the administration. And the other thing that I noticed that he put the patch both coronary side. In other words, coronary sinus was draining to the right ventricle. I think I think that's possible if you have a functioning um, pulmonary valve, but then also you have to have a good, reasonable RV. Otherwise, the pressure inside the RV will be too high, and that could be the cause for why the patient died. Maybe it was not only the fenestration, it was the, the other condition too. It's interesting that I operated a patient from Chile in Brazil that had uh, they put a patch covering completely the thoracic valve without fenestration and ligate the pulmonary valve was a freezer. So I accept the patient, but then I went there, well, perhaps this ventricle is filling, and but it was very small, but you still could recover. So if you have a fontan, not a fontan, a Glenn procedure previously, so you can invest in a very small venture. That would be my experience. So I don't know what your thoughts about that. Does you agree with that?
Um, it's quite interesting. Why I was so fascinated reading this original paper, but I think this the failure of this first 3 patients is really that you actually increase the amount of inflow into the right ventricle by leaving coronary sinus to the ventricle and rely on this pulmonary valve to open to decompress. But and then you know the surgical outcome definitely improved after they fenestrated. I have a question for you, by the way, this about coronary sinus. Um, if you think this stands as a way to bridge to biventricular repair, and then somehow you want to maintain this right ventricular viability, would you intentionally leave this coronary sinus to the right ventricle or not?
This question, if you would like left the coronary sinus in the right ventricle or not during this?
No, I think we live in the right age. I
Yeah.
think it's better. But usually we put the patch supraventricular position, supraannular position. So we suture it to the caudal tendon to prevent heart block. But then we go down to the base of the coronary sign, so the coronary sign is in the left, and in the right side, the right atrium. I think what can help, as Luciana did recently, is when you do the gland and you have pulmonary atresia, you can open the pulmonary valve a little bit, especially if it is a valve, membranous type of pulmonary atresia, because then you can have some forward flow there. And if you have a little regurgitation, at this point, you have the ventricle, the right ventricle to develop. So when you do the cone after scan, you have immediately a better oxygenation of the patient. So this is an interesting point to if I think about doing a cone after scan. But then if you have a patient with a gland, for example, and a reasonable to saturation, so it's very important if you do the cone after scan to leave the partial occlusion of the septum, I mean, penetrated patch, because that RG cannot manage the blood from the inferior vena cava immediately. But we'll send some additional flow to the line, so the occlusion saturation will be greater than it was before. And then over time, 6 months, the RG can double the size or more than that, and then you have a patient with a good 1.5 inch.
Luciana, you want to say something?
Yes, congratulations. Was really nice presentation. And I think Dr. Stearns would be proud of you. He couldn't come. Um, I want to comment that in that publication that they studied patients and compared the stars and there was a small number of stars procedure because the stars besides having a good result would commit the patient to the single ventricle pathway. But now that we can offer the cone after stars, I think there will be a tendency to decrease the numbers of trials to do the biventricular repair or a BT shunt and move direct towards the stance procedure. And then the number will increase. And then we will have a better result and a higher number of stars instead of biventricular repair trial. And the last paper that you presented is a very interesting paper about the Fontan that's doing worse in Ebstein anomaly patients. That can be related to the coronary signs to be in the right ventricular side because that decrease the amount of flow to the coronary arteries. And I think there will be a tendency to move with the cone repair, with the biventricular repair, or at least 1.5 ventricle repair in those patients. So I think that paper is very interesting too.
Yeah, I agree. And then just add that this Fontan outcome is quite reasonable after stents. That means that if you do the 1.5, that will be quite good physiology, I think, those patients.
Well, I think that's a great sort of segue to this afternoon's sessions, which we'll be talking more about the cone operation. And in the meantime, we can have some lunch.
Yeah, no worries. Okay, that's good. It's not going to. I can already see. Stop your share. And then I have to hit share down here again. But that is not the worst. The only other issue would be screen delegation, right? Yeah.
Hi, Dr. Wald. Are you online for testing?
I was just about to type in the chat to see if someone could hear me. I'm here. Yeah.
Oh, perfect. We can hear you now.
So, do I just project off my laptop, or does it go by the link that I sent to you, or how does it work?
Hi, this is Joel from AV here. So basically,
Hi.
you just share screen, and we should see it in the auditorium here.
Okay, so shall I
Yeah, you
okay,
can
so
try
I'll
that now.
go to share. Yep.
Yeah,
Okay.
yeah, go ahead and try that now.
I just need to find it. 1 second. Sorry. You didn't tell me that. Oh, I can't tell you. Leave this 1 minute. Sorry, I should actually have it ready to go. This is my problem. Stop sharing for a moment.
Sure, no worries.
Now I understand what the issue is, so I'll make sure it's on my desktop just a second. Second Symposium. Final, okay. All right, so back to here. So do I show up on the, do I show up at all, or?
Yeah, you'll need to, yeah, once you share your content, we should see you.
Yeah, I'm trying to get it up. Do you see my,
Yeah, we see your computer. We just don't
Okay.
see your slides. There you go.
Okay, so here's a question. Can I do the speaker view of this thing? Meaning,
yeah, that would be on your side here. So if you go to slideshow and
Mm-hmm.
then use presenter, where is it actually? Yeah, presenter view. Beside, yeah,
Yep,
next one over. Yep. So
Okay,
you'll have
so
to
what
stop your share and
Yeah.
share just the actual presentation. So if you go back to Teams,
Okay, go back to Teams. So let me stop share. Okay, yeah. So I'm stopping the share and
okay, so now before you start your share, go into presenter view on your slides, and then your
Yep.
command tab, go back to Teams, and then share again, and just choose the slideshow.
but the problem is when I do the the presenter view, it's like a full. I can't make it small. Yeah, I can. Hang on a second.
Yeah,
So go to presenter
you don't
view.
necessarily need to make it small, but I think if you can just switch through applications, because you're on Mac, correct?
Yeah.
Yeah, like Command Tab, or you should be able to
Command,
see.
okay, wait. So I can't, so all I see now is the presenter view. So you say Command Tab can help me?
Yeah, Command
Oh,
Tab.
yeah.
Yeah. So then you should be able to choose Teams. Just
I
like
am on
press
Teams
Tab,
now.
hold Command and hit Tab until you get to Teams. Then
I did
Teams will
it.
pop up to the forefront. Yeah,
I
and then
did
hit
it.
share,
Yeah.
and then there you're gonna share actually not the whole screen. You're gonna share just the slides. So if you stop your share one more time.
Oh, okay. Fine. So let me get out of this thing here. Stop share. One moment here. Wait a minute. In show. Okay, so back to here. Wait a minute. Yeah, stop sharing. Yeah. Okay. So I stopped.
Okay. So yeah, one more time. If you go to presenter view, then Command Tab over to Teams, and then hit share, it should show the options for what you can share.
I got it. Okay, so back to here. Okay, so let me go
You're not going to
back.
share screen one. You're going to see the options, and one of them should show like a mini version of just your slides, not the presenter view.
Okay, so I'm now back at the presentation. I go to the presenter view, and then I tab, Command Tab, which I love. I never knew that before. Then I go, so now it's ready on presenter view, and I go to share. Is that the next step?
Yep.
Click on share.
And then you're going
And
to
then-
choose the option for,
Oh.
yeah, just the slides.
So, okay, so I see there's content only, turn your camera to layout, there's all these, there's different presenter mode things. So I thought I only had the content only, but that's selected already.
Do you see, yeah, it's hard to.
Well, I'll do the share right now. You'll see what I'm looking at, no? Oh, no, you can't.
No, I know, this is right now.
Yeah.
Just trying to get to see if she can share. Yeah. On your screen, you should see different like options of like what screens to choose.
Yeah,
So
I have presenter mode, and there's one called content only.
Yeah,
there's another one.
Try
But
content only.
I actually thought I had that actually, but let's see.
I have a deadline. I have nothing else to do.
So share
And why is your
content.
Big shot?
Did it work?
Yeah, no, we're still seeing your slides, your presenter view.
The presenter.
If you can go back to Teams right now while we're seeing it, just on the bottom there.
Go back to Teams. Like 1 second. Command Tab back to Teams. Well, oh, sorry, the Teams is here. Yeah. I don't know. Why is it not letting me make this big? Oh my gosh. Maybe I shouldn't just, maybe it's just easier not to do it. So I continue with the share, you mean?
Yeah, try.
Command
I
Tab.
think we can only see your, yeah, you're gonna go back to Teams.
Yeah, it doesn't really want me to touch this thing. I don't know.
Okay, go down at the bottom. I can see your dock at the bottom.
Oh, yeah.
Just go to Teams. And then, oh, where's the actual meeting? Oh, it's over to the right, beside the garbage, the trash bin. Down at the bottom of your dock, beside the trash.
Oh, how did you see that? Oh, wow. Okay.
And then, yeah, we won't be able to see it. If you hit stop share, we're not gonna be able to see your screen anymore. But if you can stop share and then try to share one more time.
Mm-hmm.
And there should
stop
be.
Share.
Yeah, and now hit share one more time.
Mm-hmm. Oh, there's something called screen and something called window. Do you think that makes more sense?
You're gonna choose window.
Yep.
Oh, actually, you might choose.
Oh, wait a second. There's something called window slideshow.
Yeah.
Okay, now I think I figured it. Wait.
So that's what you're gonna do. Yeah, we just see the slides, and you should still have your presenter view on your computer there.
Okay, so what do you see now? Just
your
thing
slides,
says that disclosure?
Yes.
Okay, now I have to remember, what did I do there? Window. So I did the window of, yeah, okay, I got it. So when I did
Okay.
screen share, so when I won't go to screen share, I just do window, and the window is something called just the slides, wherever
Yeah,
those
you
are.
want just those slides. You don't want like your whole screen. So now we know in terms of sharing just your slides, and that's great. And then I
Oh, but
guess
wait a second, sorry, quick question. I don't see
yeah,
that anymore. I
you need
lost
to
it. Yeah.
yeah, you'll need to the way for Mac the way it works is that you'll need to first go into slideshow, then you're going to need to select your share and what window you need to share. If PowerPoint is not in slideshow, it won't show that option. Because PowerPoint is doing that work kind of behind the scenes. And
Do you
Teams
mean
won't be able to see
slideshow,
it.
or do you mean slideshow or presenter view?
Presenter view, like the presenter,
Yeah.
basically, because you don't have two monitors right now. What PowerPoint is doing is that it's creating like a false second screen that is showing the slides and showing you presenter view. And then in Teams, you're choosing that slideshow. That's not the presenter view. So unless PowerPoint is already in presenter view, then Teams won't be able to see that at all. So the next time, what happened just now is because you ended your slideshow, you couldn't get that option back again. Your slideshow needs to be in presenter view. And then once it's in presenter view, then you choose your window, share slides only.
Okay, how do I find you again? Like, how do I make this big? Can you see my screen?
No, you're not sharing right now at the moment.
Oh my gosh, I feel like I'm gonna do something wrong at this thing. Okay. Let me get out of this one. Okay, I see it now. All right, so can I just practice it one more time? So I'm already in the presenter mode on my laptop. And then what I'm going to do is go to share, go to window. But now I don't see the option. Oh, final slideshow maybe? Okay, do you see something now?
Yep, we see your objectives right now.
Okay, and then, so you don't see anything. You just see my regular, like,
Yes. Yeah, and that's
okay,
what we want
okay.
for this side.
Okay, so maybe I can just, oh, it doesn't really matter if it plays, right? Because as long as it plays on my laptop, I'm fine. Correct? Like, I don't have to
Yeah.
run through it necessarily for you
No,
guys?
from your side, it's fine. I mean, if you're good with all your slides, that's great. That's what we see on this side, and you should be good. We can hear you. It's fine. So you can like give your talk. We can see everything, and it's great. You just have to remember at that time, that's what you're gonna do. You're gonna go into presenter view, then share window, content, or the slides only, and that's it.
Okay. Share window, slides only. Okay. Now, is
great.
everybody going to watch me fumble with this? Like, is the whole auditorium going to see the whole problem?
I mean, unless you're sharing, we can't see your screen, so it should be okay. But yeah, for us to see what you're doing, you'll just need to share on your end.
Are you going to be there?
I'll be here
No.
for the very first part. It's the second part we're kind of trying to work out right now once you're done.
Yeah.
But for this part, I'll be here. I mean, I don't know necessarily that I'll be talking you through it just because everybody will hear me talking you through it. But
I know. Okay, fine. I hope it works out. I think I have everything here. All right. And you saw everything just regular, like that's it. You just see a full slide.
yeah, we just see
Oh,
your full
okay.
slides and you're good to go. And then when you're done, you're just going to stop share, or you can exit your slideshow. If you exit your slideshow, everyone will see your screen, but you can just stop share and then you're good. Yep, that's it. And then you're done.
Did I stop share already?
Yep. Yeah, you're done.
Okay, actually, when I leave the thing, I lose the presentation. Okay. All right, presenter view, share window, just the slide mode and go.
Exactly.
And where do I show up on the screen?
You're on all three screens, like your face, do you mean, or just your slides?
Yeah. Am I talking to anybody? Like, do they see me or no? Do I have to
Yeah,
open? I didn't
so-
open my camera this time.
that is the second piece that we're just trying to figure out. But we will be able to see you. It's just more about the aftermath of that. But if you want, we can. Yeah, your camera's on right now. I'm told. Yes.
I'm
We
not
don't
in the
have
right
you on the
lighting,
screens
but
up here because we'll have to route it. But we can route that. So yeah, that part is good. That's all you have to do. Turn on your camera, unmute your mic, share your content, and then you're good. And then when you're done, you can just stop share, turn off your camera, and then you're okay.
okay. And just how did you see, like, if I lose the Teams box somehow on the dot, like, how did you see it so quickly before?
Yeah, I'm not like super proficient in it as a Mac user, but like right now I can see your doc at the bottom, right? So
Yeah, so I can't make this thing bigger. That's usually my problem. Like I have it
yeah.
small.
Open applications are on the right side of your dock. And so that's Teams. But if you go over to the right, there's little tiny mini windows of what's open right now on your computer. Yours is
I
that
got
one
it.
right there is the Teams meeting. Yeah.
I just learned that. Perfect. Okay, good. I
Yeah.
think I'm all set. So I have to be back for 3 o'clock. Yep.
Yes.
Perfect.
Okay.
Joel, thank you so much.
No worries. All right.
Okay.
We'll see you,
Okay, see you soon.
soon. Okay. All right.
Thanks. Bye. Bye-bye.
Bye.
Good afternoon, everyone. Just trying to start on time. It's 1:30. Hope everyone had a good lunch. And we are, after an interesting morning, we're now heading into the Williams lecture. And I'm very honored to be the one who moderates the 2025 William G. Williams lecture. This is an annual lecture, has been established through a generous gift of the Chung family, and I'm delighted to say that Dr. Wilfred Chung has joined us from Ottawa today. In 2016, and that's roughly about 20 years after Bill Williams repaired his son's Gregory's heart at Sikitz, Wilfred and his wife Carol, they returned to Sikitz and made a remarkable commitment by establishing this lecture and the Dr. William G. Williams Research Directorship in Cardiac Data Analytics. We're all very grateful to Wilfred and Carol and their 4 children, Gregory, Hillary, Amy, and Matthew, to support us in this way. Would also use the time to acknowledge Dr. Bill Williams, who I think many of you know, and who was the one this lecture is named after. Unfortunately, Bill is not here today. I'm sure he would have wished to be, but he has a much better reason to miss out because they are celebrating their 60th wedding anniversary. So probably an even more exciting way to spend the day. Bill spent his career in Toronto, was division chief of cardiac surgery at Sikitz until his retirement in 2006. And Bill's legacy is obviously known to every one of us. Excellent surgical care. He was a great researcher, teacher, and a leader in cardiovascular surgery, and is renowned by patients and colleagues alike. The Jones family's gift and the legacy of Bill Williams, they give a fitting frame to welcome our invited speakers, Dr. Jose da Silva and Dr. Luciana de Fonseca da Silva. And I intentionally say welcome because introduction, I think, is not really necessary for the two of them, especially not in a symposium on Ebstein's anomaly. So Dr. Jose da Silva, who's going to give the first talk, he's a professor of cardiothoracic surgery at the University of Pittsburgh School of Medicine. He's the surgical director of the Center for Valve Therapy at the Heart Institute at Children's Hospital of Pittsburgh and at UPMC, and the founding director of the Da Silva Center for Ebstein's Anomaly. He's a former fellow and associate staff at the Cleveland Clinic Foundation. He's internationally recognized as the creator of the cone repair, something we've spoken about this morning extensively already, the global standard of care for the surgical treatment of Ebstein's anomaly. He has authored numerous publications, lectured extensively on the cone procedure and on pulmonary root translocation around the world. And he's followed by Dr. Luciana da Fonseca da Silva, who is also an international expert in the cone procedure in general and the therapy of Ebstein's anomaly in children and adults, but is also highly experienced in minimally invasive surgery and cardiac transplants. She directs the world's primary institute of Ebstein's anomaly at the Children's Hospital at Pittsburgh, together with her surgical partner and co-faculty member, Dr. Jose da Silva, who I just introduced. And they are both obviously a resource for the patients around the world to get adequate treatment for Ebstein's anomaly. So I'm very honored to welcome you here for our symposium, and I hand off the stage to you to start your lecture.
Thank you, Dr. Holler, for the kind comments. It's a great honor to be here presented this conference with his William lecture. He's a man that which legacy inspired the construction of this beautiful institution with so many contributions to our field. Uh, so I will speak about the cone procedure. So uh, in the past, we had the most well-known operation was the Dennison technique, used mainly in the Mayo Clinic, but in the whole North America, and then in Europe we had the Carpentier technique. And here you can see the results of the tracheal valve repair using the Dennison technique with a 30-year experience of the Mayo Clinic. So in this group of patients, they report uh, 184 patients and under the age of 12 years and with a mean of 7.1 years. So it's interesting that they did the repair in only 28% of the patient, and they replaced the valve in 63%. And this is because in this operation result in a monocusp mechanism of closure of the tracheal valve, and it depends on a good mobility of the anterior leaflet to work. This is the technique by Carpentier, where differently from the Dennison technique, he mobilized the anterior together with the inferior leaflet, but he didn't touch the septal leaflet. With this technique, he could do the operation repair in most of the patients. So in this series of 142 patients, he did tracheal valve replacement in only 4 patients. But the mortality rate was kind of high, but then you have to consider that he operated in older patient, adult patient, probably many of them with cyanosis. And that was the problem with the early techniques because they're not so efficient. They used to delay the operation uh, to do replacement in older patient. And unfortunately, the right ventricle does not cause much symptom in many patients. It's not like the left ventricle that people get dyspnea very easily. And then patients can survive a long time with very dilated right ventricle, and then you operate on them, and the result and the risk are the results can be poor, and the risk are usually high. So I had this experience from the Cleveland Clinic where I helped doing the Dennison technique. And then I went to Brazil and São Paulo, and the first patient did the Dennison technique and worked very well. Then the second patient was 18 years old boy, and he didn't do well as far as the function of the valve is concerned. Then I thought, well, we have to modify it. But then took a long time to get another patient uh, uh, to do the procedure. But then I imagined to take the valve, to mobilize the leaflet, all the leaflets that were abnormal, and try to reunite uh, the distal attachment of the valve in a small area near the apex of the right ventricle. And then I'll construct a valve in the format of a cone, and I'll do fenestration as necessary to improve the inflow. So as the right ventricle squeeze the cone, it closes and works as a valve. So, so this is the first patient. It would be my third patient with Ebstein anomaly in Brazil. And she came, and the cardiologist was a good friend of mine, and he said, "Oh, this girl, we need to do a repair on her by all means because she, her father has cancer, and her sister also has cancer. So both of them are, she'll be the only one in the family, and she want to have babies, and so on and so forth. So I said, oh, I'll do my best, and I have the design of the operation, and I did it. So the first one in November 5, 1993. But at that time, I didn't mobilize well the leaflet, so there was some tension in the suture line, and she came back to be reoperated 4 years later when she was 16 years of age. And then I got it right. And see here in the middle, you can see the MRI 25 years after the first operation. And you see that the valve open and close very nicely. The attachments are near the apex. So this gives an idea of a cone. And here in the right, you see the same thing, pulmonary valve, the right ventricle. There's some dysfunction, some enlargement, but the patient was able to have the babies, two kids actually. And she's alive and well. Uh, and now 32 years after. In the first operation, Luciana was there. So, uh, of course, that's not the picture. This one was at the UPMC in Pittsburgh. Here in the right, she designed a sculpture in the format of a cone to celebrate 30 years of the cone operation. Here you can see a case, a real case, where you have the anterior leaflet uh, tethered, but with some mobility. The inferior leaflet was displaced uh, and tethered to the wall of the right ventricle. And the septal leaflet was hypoplastic and also with a very little mobility. Uh, so like Dr. Yu shows us this morning, near the anteroseptal commissure, it is nice, it's not so displaced. But here, when you go inferior, it is very displaced. So we took down the anterior together with the inferior. Then we made an incision here at the anteroseptal commissure. And, and then we rotate the inferior leaflet without this attachment and connect it to the septal leaflet. So the septal leaflet has become the uh, the structure, I mean the subvalvular structure for the inferior leaflet. Uh, and then in the right, you can do saline test showing that an excellent result. Here is another case where you have the inferior leaflet is somewhat displaced. There's a septal leaflet, it's very displaced, and there is a gap between the septal and the inferior leaflet. So in this case, I started by taking down the septal leaflet. See that I take down the papillary muscle to make it longer and improve the mobility for the leaflet. Then I made an incision at 12 o'clock in the anterior leaflet hinge line and went to the right toward the inferior leaflet. Then I cut all the abnormal leaf attachment to the RV. See, the valve was not that bad except for the septal leaflet. Then I connect the septal leaflet to the anterior leaflet. Usually I put interrupted suture. And then the inferior leaflet to the septal leaflet. Then I close the anterior-inferior commissure. And then I decrease the size of the annulus in two spots. And then I start, reattaching the valve. So I note that if I want to reattach it, I would distort it. So I put a patch to enlarge the septal leaflet. So, and this is a autologous pericardial patch. I suture it supravalvular to avoid heart block. Then I go suture it to the anterior leaflet, medial edge, and then to the annulus. See, that looks strange, but it works. The distal part of the valve is all normal tricus valve leaflet. And finally, I finish the reattachment. I'm gonna test with saline. So it's completely competent. My assistant was a little, didn't believe so much, so he wanted to check again, and the fluid was still there. And this is the echocardiogram 6 months after the repair. See that the septal leaflet is supravalvular, the capitation is perfect, and there's no regurgitation at all. In some cases, the valve has little displacement, like in this one, this drawing in the right and the left. But in some other case, the valve is extremely rotated and opening toward the outflow tract. This drawing was based on a patient who was 10 years old when he died because he had dilated and thin wall outflow tract of the right ventricle, pulmonary regurgitation, probably because of this type of anatomy, and a small functional RV with severe tracheal regurgitation. So in this situation, the RV does not dilate much because the valve leaflet prevents the dilatation. But the atrialized portion of the heart is dilated. And this patient had a lot of arrhythmia as well. So Schreiber from Germany and Anderson, Bob Anderson, wrote a paper showing the many positions of the many different intensities of rotation of the tricuspid annulus in Ebstein anomaly. So it can be very little rotation or it can be extreme rotation. And in the past, they used to say that the valve that have severe leaflet displacement in the RV apex, or those anterior rotate into the RVOT, are generally not suitable for the traditional monocusp repair. This was written in 2008. And here we can see a case where you can see in the left that the leaflet is very rotated. And here's the pulmonary valve. And the valve, there's some attachment very close to the pulmonary valve. And here you see this patient had already a gland. So this injection that was done through the gland shows a small functional right ventricle. And here you see the opening of the tricuspid valve. And here in the right, you can see the result after the repair. So the valve became competent. And so it's possible to do using the cone repair. So this is another example of extreme rotation and pulling the valve to show the leaflet. And in this case, there is a discontinuity between the septal and the inferior leaflet. And we had some attachment of the anterior leaflet very close to the pulmonary valve. So what I did, I cut those attachments near the pulmonary valve and I suture the attachment in the septal leaflet, I mean, in the distal septal leaflet. So I did like a translocation of the of the anterior leaflet attachment. to the middle because I want to centralize the apex of this valve near the anterior wall of the right ventricle. And then I finish the cone, and here you see the result. I want to call attention that in many situations, we used to take down too much the anterior leaflet. And then there was a tendency to ballooning the anterior leaflet. Uh, in this, here you can see it. So the anterior leaflet is taken down until the end of it. And now we tend to take down the, we tend to take down more the septal leaflet and make the apex here. I think with this we give more support to the right ventricle, and therefore I think result in a better function in the right in the long term. Well, Luciano is going to talk about this, but we want to say that since 2019, we start doing the cone after Starn, and Luciano is going to show you some of that. And but it's a very interesting operation because it allowed to do a case like this with in cardiogenic shock where you can do the Starn, and in the future you can do the cone after Starn. And 6 years after, you see a patient with a nice right ventricle and also left ventricle. And in this case, the only thing it was pulmonary atresia, so we need to do to put a conduit, a monocosp in the pulmonary valve position. So since I started we started the Children's Hospital of Pittsburgh in 2016. We start very slowly, doing a few cases, like 5, 7 per year. There's a COVID problem. But then during the COVID, we sought a little bit more than did and came up with the cone after Starn. And also because of the result, we start to have more and more patients. Last year, we operated 32 patients. This year, we expect to operate at least 40 cases in a year. And we have 19 cases. Now we have 20 cases, actually, of cone after Starn. And this is our results. This was collected, I think, was in February. And the whole experience is over 400 cases, many of them done in Brazil, but we did some over 50 cases outside of Brazil in the United States, like in Europe, India, and South America. And so we had the opportunity to get a lot of experience, and we did in all those cases only one tracheal valve replacement at the first operation. And we operate in most of the patients between children between 13 months and 18 years, with the counts for 66%. So far in Pittsburgh, we have had zero hospital mortality. We did late replacement. Now we know about another one. We have 2 late valve replacement. We have 1 case of transplant. We have about 3% of valve re-repair. Regarding late death, we had all of them not related to the heart. One was brain tumor, liver bleeding, and non-cardiac complications. And the one thing that we are proud is that we start preoperatively. Most of the patients have severe regurgitation. And with time, now we have excellent result as far as the valve is concerned, function as concerned. And we have like in green is minimal regurgitation, trivial regurgitation, or mild regurgitation in about 90% of our patients at the discharge, hospital discharge echocardiogram. This is an example of a patient 18 months postoperatively. So you see that the valve that look like a cone, very small regurgitation, good RV function. But actually, RV function has been a problem for about 5% of our patients, a significant problem. But many patients have a bigger RV, but the bigger RV works is result of the operation. Because when you have a small functional RV, then you bring the valve to the normal AV junction, so you increase the size of the ventricle. And then by detaching the valve, sometimes you have a bigger ventricle, but it works well, and the patient doesn't have symptoms. So you have just to follow, but some patient will keep dilating. And that's the problem that we have to address. We are studying that and see what we can do either clinically or mechanically. These are the results with my 54 initial patients in Brazil. They started preoperative echocardiogram, showed significant regurgitation in most patients, and then it improved early postoperatively, and then in the long term, it maintained the result, which is very important. With the monocos, for example, if you're doing kids, then the anus can grow more than the leaflet, and then we start to have regurgitation. Why with the cone? Because it's 360-degree structure. It grows with the patient, normally keep the result in the long run. This is another work supporting that concept, and that was done at Munich group, and they compare the cone repair in pink with the old operation in blue. So the incidence of moderate tricuspid regurgitation was progressive in the group that they did the traditional operation. While with the cone, the result was maintained over time with the same as incidence of severe tricuspid regurgitation. Very few patients, the cone acquire severe regurgitation over time. Regarding arrhythmia, I just want to say that we do studies in patients who have evidence of supraventricular tachycardia or other type of arrhythmia, but we always do indeed surgical ablation 64% of the patient. But nowadays we do CTI ablation. We did a line of ablation between the tricuspid valve annulus and the inferior vena cave in most of the patients. The reason for that is to prevent atrial fibrillation, because when you do a big incision in the atrium, you can create focus of arrhythmia, or re-entry arrhythmia type. When they have WPW, that is easy to resolve in the cath lab. They do it, so the P group does it by themselves. This is the conclusion about the expert consensus of the ATS done into 2025, and surgery is recommended for symptoms that include fatigue, decrease in objective exercise tolerance, and this and cyanosis, and also exertion of dyspnea. The cone repair of the tracheal valve is beneficial when the surgery is indicated. Uh, Surgery is also recommended when there is severe tracheal regurgitation and progressive RV dilation or dysfunction on stereo echocardiogram or resonant magnetic image, even in patients without symptoms. And surgery can be beneficial in a symptomatic patient when there's severe tracheal regurgitation, moderate RV enlargement, and valve anatomy favored for repair, which is between among the expert people is always almost always favored. So it's very rare not to be. Um, and the one thing that we have the notion when I was in Brazil doing old and young patients, at the beginning we have very sick old patients with Ebstein anomaly, but and kids too. But we never lost a patient under 15 years of age, and over completely different from the older patient, especially if they have cyanosis. So we think that there's some papers supporting this, but performance surgery in younger patients enhance the likelihood of successful biventricular remodeling. Uh, and the other thing that is a concept that uh, if the patient is not severely symptomatic, it should be done between 3 and 5 years of age. But this is discussable because if you have a patient over a year of age, the result is very good, the risk is very low. So you should do the operation if they have any enlargement of the right ventricle uh, or dysfunction. And at that time, if we have severe dysfunction, the patient has severe dysfunction of the right ventricle, should associate a BCPS, a shunt, like a Glenn procedure. So I summarize, say that the cone repair is effective and durable, with rare need for tracheal valve replacement, even severely rotated valve. About neonate, Luciano is going to speak more, but neonate with critical Ebstein anomaly can benefit from the stage approach by performing the starting procedure in the neonatal period and cone repair later on. We can do the cone after prosthesis too, implant. And I will say that the right ventricular dysfunction in Ebstein anomaly requires further investigation, treatment improvement. I want now to show my group of the Silva Center for Ebstein Anomaly, or UPMC, and Dr. Victor Morel had the idea to form that center, which is very helpful to understand better this challenging disease. And here we have also Jacqueline Kreuzer with the chief cardiologist. Thank you very much for your attention.
Thank you very much. I think we'll just go on with the next presentation and then regroup for the discussion at the end.
Thanks so much for the invitation. It's a pleasure to be here, Dr. Sid, and all the team from Sick Children, Sick Kids. And to talk about Epstein for me is a pleasure. I think, like Dr. Lisa said, it's a passion for some of us. So it's like to be in a club, the Epstein Anomaly Club. I will talk mostly about the staged treatment for newborns. So like was previously described earlier today, the mortality in the surgical treatment for Ebstein's anomaly was high, and mainly because we were trying to avoid the single ventricle pathway with the stance procedure. And nowadays that we can do the cone after stance, I think that will change a little bit with more centers habituated to do the stance procedure. In this paper here, the mortality was presented before this paper by Dr. Ronjo. The mortality for surgical intervention was 27.4%. The stance procedure is the exclusion of the right ventricle, transforming the heart in univentricular physiology, and it presents many benefits, and mostly to allow better left ventricular filling and improving the systemic perfusion. And decreasing the size of the heart will allow also more space for the lungs and for the ventilation. So usually the patients that are submitted to the stance procedure are those that are very sick, and they have a better result doing the stance than any other um, type of operation. And the advantage of the stance is that it's a reproducible technique, so it's possible to do the stance in any center that has experience with and good results with neonatal uh, surgery and not habituated with Ebstein's anomaly, because we understand Ebstein anomaly is a rare disease, so it's easier to do the stance and to keep the kid, to maintain the kid alive, and then later on to come back and do the cone repair. The right ventricular undergoes a progressive involution after the stance. It's very clear. We can see that in many papers, in many presentations. And usually the stance would commit the patient, as I said, to the single ventricle pathway. But in 2019, we thought that at some point in this reverse remodeling process, the right ventricle would be still suitable for to work as a pump, and then we decide to move forward and remove the patch of the stance and do the cone procedure. So our first paper was published in 2020 with 2 patients and with pulmonary atresia. So we removed the patch, the stance patch. We saw the tricuspid valve underneath there, and then we did the cone repair, and at the same time we need to do repair of the pulmonary valve that in those cases were case of pulmonary atresia. And we know that we would find the valve there because we did touch the valve at the stance procedure, and we had previously done a case in Brazil where 12 years after the first operation, I took out a prosthesis in the trachea position that was placed in another service, and I found all the leaflets underneath the prosthesis, so we proceed with the cone repair. So that was the way we convinced our cardiologist in Pittsburgh that we would find the tissue there, and we would probably be able to fix the valve. And here is one of the patients, one of the first patients that we did. We can see the difference in the left ventricle that's feeling better after the stance, and after the cone, we can see the pulmonary valve is functioning okay. It was a case of pulmonary atresia, and with adequate ventricular function. One of the questions is that if the gradient in the stance patch makes any difference for us to do to proceed with the cone or not. The answer is not. This patient here had only 11 millimeters of mercury gradient, and after the Glenn was 19, and in the long term, after like 2 years after the cone, we can see the function of the right ventricle is adequate and the size of the right ventricle is good too. So we don't take into account the gradient in the stance patch. Another situation is the circular shunt, was presented before. It's a critical situation, so many patients will benefit from the fetal treatment with anti-inflammatory medication. This was a case that was treated in Brazil, and the kid survived intrauterus until the 34 weeks when she was 2.1 kilos. And then our colleague, Rodrigo Freire, did the stars procedure with a pulmonary artery patch closure, and later on, Dr. José da Silva performed the cone and the pulmonary valvuloplasty at the 5 months of age, activating biventricular repair. And this is the surgical images with the patch of the stars death and the valve reconstruction. And here in the left, we can see the patch of PTFE covering the pulmonary valve to close the pulmonary valve in a way that will not destruct the leaflets and will make it possible to do the biventricular repair, preserving the pulmonary valve leaflets. So thinking now in the future, in the cone repair and the biventricular, the right ventricular rehabilitation, we need to be careful while doing the stars procedure. Was mentioned before, we use the Gore-Tex patch to cover the tricuspid valve. We suture it in the Todaro tendon, always leaving the coronary sinus in the right atrium. And it's a fenestrated patch. And if in the case when we have pulmonary insufficiency, then we close the pulmonary valve with a patch inside the pulmonary valve. So later on, it would be easier just to take out that patch in the pulmonary position. And if the patient is too small, like that one, 2.1 kilos, usually we do a conduit, a PTFE conduit from the innominate artery towards the central pulmonary artery. So it's a longer distance conduit that will not create over circulation. It will be even distribution to both lungs. And if the patient has adequate pulmonary valve, we do not need to cover the pulmonary valve. We just keep it the way it is. Or if there is pulmonary insufficiency, we place the patch. And in those patients later on, at 5 to 6 months, we can follow with the biventricular repair. Then reconstructing the tricuspid valve and removing the patch in the pulmonary position. So this is a patient that was born with a circular shunt in another institution, and he was severely decompensated, was born in the operating room, and the surgeon took him to the next room without doing a postnatal echocardiogram because the kid was so sick. So to evaluate the size of the right ventricle, we used that fetal echocardiogram to know that there was some cavity there and there was like adequate RV function and severe tracheal regurgitation, and we can see muscularized leaflets here. And this is the pulmonary valve in that patient. So we based on the fetal echocardiogram to indicate the surgical procedure. So the patient was submitted to the STARS procedure, but unfortunately they divide the pulmonary artery and removed the leaflets of the pulmonary valve at birth. And later on, they did the M-Fontan procedure at 3 months, and then the patient came to us to do to try to do the biventricular repair. So this is the exposure, the stars patch, the large atrial septal defect, and then I start removing the patch from the central orifice to the border. We need to be very careful while removing that patch to avoid to damage the leaflets that are underneath there. This was a patch that was a little bit more difficult because they used a pericardium patch, so it caused more adhesions to the patient tissue. So we took out all the fibrous tissue, and then we are exposing the valve now. We see it's a very severely rotated and muscularized anterior leaflet. And then we start dissecting laminating the anterior leaflet from the wall. We start at the level of the annulus, and you can see the leaflet is attached to the wall. So we shaved the leaflets from the muscle. Sometimes if we create some orifice like this small here, we need to close later. But then slowly we continue delaminating the leaflets. Even deeper on there are short papillary muscles that we need to cut and to use most of the tissues that are available to us. Here we are in the septal region. We see there's a huge gap of tissue here in this region. And the inferior leaflet we are detaching also now. And then we start reconstructing the cone. Here I'm detaching more the septal papillary muscle to elongate it, to allow larger excursion of the leaflets. Here elongating more the other papillary muscle too. And we need to be careful because this was like a linear distal attachment of the anterior leaflet. So we need to see how would be the inflow of the blood to the right ventricle. Here I'm still cutting the attachments to the wall, and here creating distal fenestrations in that distal linear attachment. So the inflow from the right atrium to the right ventricle will happen in those created fenestrations. And then we start suturing back the leaflets to the annulus. Usually we do not need to decrease the annulus because the patch hold the annulus in size there. So the ventricle decreases in size and the annulus is small. And we complete the attachment. We continue distributing the valve. And in some patients, we need to use a piece of pericardium patch in the septal area, in a small portion of the septal area. Here we are still constructing the cone. It's a little bit too long, the video. So here we are completing. And in this region, we decide to suture a patch to enlarge, a patch of fresh autologous pericardium, suturing the proximal portion of the septal area to increase the excursion of the septal leaflet. So after suturing, we suturing the Todaro tendon to avoid heart block. The heart block can be another problem during the STARS procedure. We received a patient that had a heart block and pacemaker implantation, and now we have another one that's coming to do the cone with a heart block and pacemaker. So that's the reason during the STARS and during the cone we should suture upper in the Todaro tendon. Here we are closing some orifice in the leaflet. Then we will do the test, and the there is a competent tricuspid valve. And then we go to the RVOT, we need to recreate a right ventricular outflow tract. Unfortunately, like I said, the valve was destructed in the previous operation. And then we open the main pulmonary artery. And in this case, was far away from the RVOT, so we used conduit constructed with a 3 leaflet PTFE. The distal anastomose, and then we do the proximal anastomose to the RV, like we do in the Rastelli patient procedure. To close the ASD, we always use a fenestrated patch to close the ASD to allow some right atrium to right ventricle to left atrium shunt, and then we close the right atrium in a regular manner. The patient came out without heart block. And then this is the result with a good ventricular function, almost no regurgitation, and no significant gradient. So in patients with anatomical pulmonary atresia, we prefer, we also, when we did the stents previously, or a BT shunt, we do a Glenn at 5 to 6 months, and then the con repair at 12 to 18 months with a 1.5 ventricle repair. And usually we open the pulmonary valve with a small commissurotomy during the Glenn to stimulate the growing of the right ventricle cavity after the stents. So this is a newborn with severe Ebstein pulmonary atresia, the stents, and the BT shunt. And then 6 months later, I think it was the same patient that Jose showed, with a good condition, RV function, and good tricuspid valve function. Oops. Now, how we evaluate the suitability of the right ventricle to do the con after stents. We use the echocardiogram, like I said, but the echocardiogram doesn't show very well this effective size of the right ventricle. The same with the MRI, because it's an empty chamber here. And the heart catheterization by injecting under pressure inside the right ventricle will show us better the potential of the right ventricle to fill. And here we can see the difference between the MRI and the heart catheterization in the same patient at the same time, showing that the right ventricle is a little bit bigger than expected by the MRI. And also the heart catheterization will show us the distance between the RVOT and the pulmonary artery. Here is that patient. The estimated right ventricular and diastolic volume by the MRI was only 9 cc's per kilo. In the post-op, the 14 days post-op showed a good right ventricular size for 1.5 ventricle repair. We also did a case, Jose did, a case that had a Fontan procedure in Ebstein's anomaly after stents, and the size of the ventricle was not as big by the MRI, but the patient was symptomatic. And then after the con after stents, the right ventricle immediately after was already a little bit bigger. So we need to think that the patient will deal just, the right ventricle will deal only with the inferior vena cava volume. So here was the data published in 18 patients, 2 of them performed in Tampa, just to show that most of them, they will achieve normal or low normal RV function and a good result with the tricuspid valve. Now we have 20 patients that we offer the cone after stents, and one of them, none of them died in the hospital stay, and one of them that was very critical was a patient that was previously had some stroke and was under the work to do a liver transplant, came to us to do a stars. We accept doing that to improve the O2 saturation and avoid right to left shunt to make it better for the liver transplantation. But the patient had already tracheostomy, so 2 months later she had problems at home with the trachea, and then she had an arrest, a respiratory arrest at home. She was hospitalized. The heart was functioning well, but she went on brain death due to the hypoxemia. This was previously mentioned. The neonatal stents is now like a procedure of choice for critically ill neonatal Ebstein's anomaly in most of the centers. And patients that are stable with inadequate pulmonary flow, they can have a stent or systemic pulmonary artery shunt. And it's open for a biventricular repair or single ventricle repair palliation in those patients. This is the fluxogram that we use in Pittsburgh. Not almost many patients will not require any intervention in neonatal period, and then they can go home. But those with pulmonary atresia, we evaluate for if it's possible functional, we can try to wean the prostaglandin like most centers do. And if it's anatomical, we will follow with a BTD shunt or PDA stent or direct to the stents procedure. And the circular shunt, immediately after we need to close the PDA, and if they are not doing well, we do the stents procedure. But at the end, all the patients will benefit from the cone repair. So the neonatal Ebstein's anomaly, in summary, we should start working on them in the fetal life. Their rehabilitation with the cone repair provides excellent clinical outcomes, encouraging the use of stents procedure in critically ill neonates with Ebstein's anomaly, and preserving the pulmonary valve and the tricuspid valve during the neonatal intervention is essential to facilitate the subsequent steps in this approach. I just want to show the case that we did the tricuspid valve replacement after the tricuspid valve repair after replacement. This is the patient that we did in Brazil with a prosthesis, and then 12 years later with a good, after 12 years after the repair, he was doing fantastic. The other patient was a 47-year-old operating in Pittsburgh with 4 previous operations. This is the prosthesis with a stenose, and we removed the prosthesis and the cone repair. So in summary, the cone is effective and durable with rare need for tricuspid valve replacement, even in severely rotated valves, as Jose said. Neonates with critical Ebstein's anomaly can benefit for a staged approach. The cone repair after the prosthesis implants can be viable if the valve leaflets were preserved in the previous procedures. And like Jose mentioned, the right ventricular dysfunction in Ebstein require further investigation and treatment improvement. Thank you so much. We are open to questions if any.
So first of all, I need to encourage everyone to use the microphones. I think it's been an issue already in the previous session, so make sure it's a solid light there that people online can hear it. And I'll also check on the chat online that we consider the questions coming out of the audience virtually. So yeah, I think Mike, you wanted to ask a first question. I was told I repeat your question if you don't, or you just come up to the. Yeah.
Thank you for those wonderful lectures. I think you've shown us the innovation that has got us to here, but also the way forward with this fascinating condition. So thank you very much for that. I'm really intrigued by the comments about the size of the right ventricle and the MRI data that you showed, because I've often looked at those ventricles and thought, oh, it must be too small. The other thing I wanted to ask was about the function of the ventricle, because the other thing that we look at is a ventricle that's not moving at all, doesn't seem to generate any pressure, and yet you have faith to go ahead. So how do you decide about that?
So, to start from the beginning. All right. So, yeah. So as Luciana shows, after the valve replacement, the valve, all the three cases that we had valve replacement previously, the function of the right ventricle was good. So that inspired us to do also in the other case, because they were stenotic, so that made the ventricle to become smaller. Uh, and then when you do the Stern procedure, you leave only a small hole in the patch, so that makes the filling pressure of the right ventricle to be very low. So we have very low and diastolic pressure in the right ventricle. In consequence of that, the right ventricle starts getting smaller and smaller. But interestingly, the the atrialized portion of the right ventricle get a little thicker with time. And then we do the repair, but we don't count that much in the right ventricle, except for a few cases. But so we leave a fenestration. So in case of 1.5, the ventricle will manage the inferior cave flow, and then you have the ASD, the residual, the fenestration, that can prevent low cardiac output, and that can be managed, can be enlarged if you need to. And over time, the RV start growing. So the O2 saturation at the beginning, if you have a gland, would be like 80%. With this procedure, become 85, 88 sometimes. Other time they go much better. For example, the case that Luciana did the gland and open the pulmonary valve during the gland procedure, so the ventricle become bigger. So start with 92% O2 saturation. So and then the heart start growing, and interestingly, they perform better than if we start with kid with a baby with a bad ventricle. You expect then later on to have a bad ventricle or not so good ventricle. And in this case, with over 20 cases, we did in Brazil too, so we have about 30 cases. And one case didn't have a good ventricle performance, good right ventricle performance. So now, just talking about the evaluating the function. If you, because you don't have variation the volume, you don't see, it's hard to evaluate the function of the right ventricle of the start. And then when they did, in one case that they did an injection through that hole, they put a catheter and inject some volume there, so increase the volume. And then you could see that the ventricle was beating well. That was a case that was turned down by an important institution. And they say, well, when they did the heart catheterization, well, that proved what we always thought, that it's just you cannot say what the function is, but probably is well. Maybe we have to change the method. Maybe something to see the myocardium itself, but not the contraction, because you don't see much variation. In some cases, you see it. We had a case that had a 50 gradient, 40 or 50 gradient through the whole, so the trachea valve, because there was a dehiscence of the patch. So that allowed the vent to become bigger. And in face of the pulmonary atresia, the pressure inside the ventricle was greater. I don't know if Luciano wants to.
And all the cases, when we finish the con after it starts, we measure directly the pressure in the right atrium, and it's always lower than 10. So that means that the pressure that the liver will be subject to in the long term will be lower than a pressure that he would be submit if he was submitted to a Fontan procedure. That means even those patients with bad right ventricular function with a competent tricuspid valve, the pressure in the right atrium will be low. And that in the long term, we expect that will be better than a Fontan physiology. That's the main reason we try to do the con repair in those patients.
Do you have any rules of thumb about RV volume or anything like that that we could
we base
remember?
mostly in the image on the neonatal period because it was a big heart. If it shrink, even if it's not as big in the beginning, we believe that there is a tendency that that ventricle will grow with flow going through it. So that's the reason during the Glenn procedure, I try to open the pulmonary valve to keep some flow going through that ventricle to keep it the process of growing. So when we decrease the size of the atrial septum with a patch of the fenestrated patch, we will force the flow to go through the ventricle, and then we expect that that ventricle will get bigger with time if it's not enough. And we can adequate the size of the atrial septal communication. Like if we don't have if we have an elevated pressure, we can enlarge a little bit more the atrial septal communication at the expense of some desaturation, the immediate post-op, until that ventricle grows. But we never had to enlarge the atrial septal defect. Always the pressure was low and the patient was doing well.
And one last question. How do you decide whether to do the Glenn or not?
That's an interesting question. Most of the patients that came to us to do the con after stars, they had already the Glenn performed. And many of them, they had the pulmonary valve destructed, like damaged during the stars. So that's some culture that we need to change in the mind of the surgeons to try to preserve as much as possible the pulmonary valve. To add the Glenn, we do like in the pulmonary atresia, if there is a good patient to do a gland, we would follow with the gland and later on come back in a safer situation and do the cone and active 1.5 ventricle repair. But if the patient is not adequate for a gland, then we need to explain the family that we can try to do the cone, but will be a higher risk situation, a higher risk procedure. And we did that. The second case was a patient that was not suitable for a gland, and we did the biventricular repair. At the beginning, we considered to refer the patient to heart transplant because she was not doing well. But then the family said, no, we don't want a heart transplant. Can we try to do any other thing? And then we made the decision. And she's doing great. She is now 7, 6, 6. We need to replace, we need to replace her pulmonary valve 1.5 years ago because she was pulmonary atresia. So we need to replace the valve. The monocusp start working, and the right ventricle was getting bigger. So we replaced her pulmonary valve, but the tricuspid valve is working perfectly, and she's doing clinically very well.
Yeah, this patient was interesting because she had also stenosis of the pulmonary vein in the lower lower left pulmonary vein because of compression through the heart, and she had a and bronchoamylation. I think now she's about to get rid of the tracheostomy cannula. Yeah, but so in the beginning, the heart generated about 42 millimeters of mercury during systoles. So it was kind of risky to do. But the other thing I want to call attention, if you have a competent pulmonary valve, then you can do biventricular directly. If the O2 saturation is not very good, you can add a shunt. We had a case like that too, that they did a gland, didn't tolerate gland, they took down the gland, but she had good pulmonary valve.